be discussing for about the next 40 to 45 minutes, and we'll definitely make it worth your while. And I want to thank you for attending this live stream, whether you're on Facebook, LinkedIn, or YouTube. And I just want to let you know, if you're here tonight and you're here from the beginning, just let me know you're out there. I'd love to know who's there, where you're from. And we usually have educators from around the country. So it's a privilege to have you with us. If you're checking this out for the first time, the goal of this live stream is to really serve the needs of educators. And I'm going to have a dialogue with an experienced educator in Oregon in just a few minutes. And, the goal is to really bring kind of milk and maximize what we can learn from other educators and what they're doing to strengthen nursing education in their context, so we can all learn and grow together. And I want to let you know that this live stream doesn't have to be watched live. I'm glad you're with me tonight, but the bottom line is that this live stream is recorded automatically on Facebook. If you go to my Facebook page, KeithRN, Think Like a Nurse, you'll see in the header there in the middle of the page, there are, we've been doing this since about May of this year. We've got numerous previous live streams. In fact, last week, we just had Patty Ruther, the Director of Simulation and Practice at Binghamton University in New York, share some powerful and practical strategies to really rock simulation as well as virtual simulation to really develop the clinical judgment and what you can do in your program. So be sure to check that out. And if you by chance have other faculty that can't make it tonight, go to my Facebook page. And again, you can copy and paste the link and really get the word out and appreciate any word of mouth that you're able to do. And I want to let you know, my name is Keith. I'm the CEO of KeithRN, and my passion in what I do to serve the needs of educators is to develop the clinical reasoning resources and tools that educators need, because you don't have a lot of time. And especially in this pandemic, I think we're all scrambling. And so my passion for the last 8 years has been to develop educational best practice tools, unfolding case studies derived from my lens of current clinical practice, to really bring those practice realities into your program, to innovate classroom learning through some very simple to complex case studies that are writable PDF documents. And also the scenarios have been derived, most of them, from my lens of clinical practice. And I'm excited to have with me tonight Jane Morrow. Jane is a professor of nursing at Central Oregon Community College, where she's been a department member since 2003. She received her Master's of Science in Family Nurse Practitioner from Washington State, and her experience in nursing before she went into education in a number of areas, from critical care to hospice, but absolutely loves teaching. And so she's had experience in the last 17 years teaching all areas of the program and currently teaching first-year fundamental students. But in addition to her teaching responsibilities, Jane is also the department chair and lives in Bend, Oregon, where she enjoys outdoor activities, especially cycling. And so I'm going to bring in Jane with me tonight. And Jane, thanks so much for taking time out of your schedule. It's really a pleasure to have you with me tonight.
Yeah, it's really fun to be here. Thank you.
You're very welcome. And Jane, I love to just kind of, every nurse educator has a journey and a story. It's kind of like, when you look at your story as it relates to nursing and kind of making that transition into nursing education, I just love to just briefly share kind of what attracted you to nursing and what that journey has been, and then kind of that shift into nursing education and what motivated that for you, which you kind of stayed with it. So I just love to give us just a brief thumbnail, but I'd love to get your story.
Okay, well, sure. I was probably like a lot of 18-year-olds and had no idea what I wanted to do. And my mom had a friend who said, I think you'd make a great nurse. And so there you go. I went into nursing. And it worked out really well for me. So I've really loved it. Like I said, I worked in a number of areas. And while I was a critical care nurse, I had this idea that I think I would really love being a nurse practitioner. So I went off to graduate school. And as luck would have it, it was really difficult to be in graduate school and keep my critical care nursing job. So the local community college was hiring. adjunct faculty. So and that had a lot more flexibility with my schedule. It just made it much easier, with the kids and the school. And so I started teaching, and I finished up my nurse practitioner degree just in time to realize that there was no way I wanted to be a nurse practitioner, but I really loved the teaching part. So there you go.
So you never worked as a practitioner, even though you had
never worked as a practitioner.
Degree, you didn't work in that context, but you had enough education to say, you could go into nursing education.
Yeah.
And so that was back in 2003.
Mm-hmm.
Okay. And so what are some of the roles that you have done in those 17 years, and then bring us up to speed with where you are today?
Okay. So yes, I've actually taught totally a little bit longer than 17 years, probably closer to 20 if you count some of the part-time work.
Yep.
But I moved here to Bend in 2003, and I got a full-time nurse educator job. I think you realize pretty quickly once you start teaching that you need a little extra help in the teaching department. I had lots of clinical experience, lots of, the nurse practitioner program is pretty rigorous as far as learning about pharmacology and pathophysiology. So that part was great, but how to develop teaching plans and how to be an educator, I got from attending a lot of conferences. So, okay. And when we were talking earlier, you mentioned Linda Caputi, and she is just one of my favorites. I've got a number of her books, and
yes.
Yeah.
And so did you find that to be, is there any one tool, it's like, let's go back, because, we've talked about 2 weeks ago about that difficulty of transitioning from the role of nurse in the practice setting to being an effective educator. So I would love to know, Jane, is there if there's one or two books or a website that you have found most helpful to really get some really nuts and bolts information to really strengthen your practice as an educator, what would you recommend?
Definitely there's some conferences I went to. So the Elsevier conference, there's a nuts and bolts with Nurse Tim. I've done that one. Yeah. And I believe it is the Elsevier boot camp that I found really, really helpful.
Yeah, I think that's Iggy's. Iggy's got the boot camp. Donna Ignatavicius, or Iggy for short. Excellent. And so what are you doing now? What is your current role, Jane? And we're going to kind of get into fundamentals, because we're going to talk about fundamental students from that first year, how we can strengthen that development of clinical judgment at that very infant stage of their development. But bring us to kind of where you are right this moment.
So right now, I've been teaching in the first year of the program now for about, I want to say 5 or 6 years, probably closer to 6. I was in the second year of the program for a long while. So I should probably say I teach at an associate degree program. So students spend about a year or two getting their prerequisites done. They are admitted into the first year of the program, and it starts with fundamentals. And then we move on to basically, first year nursing skills. By the time they're done with the first year, they can sit for a PN exam. And then we finish up the second year and they get their RN. And then we have agreements with a number of schools in the area and actually around the state to finish up their bachelors. So that's just a little summation of our program.
But you like fundamental students.
I love fundamental students, yes.
Now for me, I'm a critical care nurse. I did fundamentals for 1 year, Jane, and it was like, they're wet cement. They're all over the place. Yeah. But I really kind of gravitate to that little bit of a foundation with advanced students, but I'd love to know kind of what is it about fundamentals? Because I think we all have that sweet spot as educators. We kind of gravitate to certain levels. I'd love to know just kind of what it is about fundamental students that you.
Oh, I love the fall term students. Coming in the fall, they're brand new. They're so excited to be there. And everything you teach them, they're just listening to your every word. And I just find them so much fun to be around. Yeah, they're so enthusiastic.
Do you find it a struggle to maintain that enthusiasm? Because sometimes, nursing school is hard. The resiliency starts to soften. And by the end of the semester or year, they're just kind of like, they're struggling. Do you
Yes.
find any ways to kind of keep their joy or to keep that enthusiasm despite the stress? Is there anything that you found? I mean, how do you see it?
Um, I think as an educator, being there for the student and being willing to work with them, ask them questions. You have to understand that yes, our students work really, really hard. Most of them are non-traditional students, so we don't have a lot of those 18-year-olds getting a lot of support from home. A lot of it is working moms. Um,
A little more mature, so they already have a little resilience being a mom. They've got
yeah,
some of that.
yes. So they do have some resilience. So maybe you don't have well, I think every school probably deals with students and some issues. So, but I think being willing to listen and understand, and if you're there, I think our program has a really good um, philosophy that we are there to help the students, and we want everybody to make it through the program. We are not there to try and call anybody out. You've worked hard to get to this point, and we know you can do it. It's tough to get into the program, like a lot of programs. And if you made it this far, you are smart enough to make it through. So,
And so when you look at where you're at with fundamental students in the classroom, what are some of the challenges that you're facing right now in this context, and what are you doing to strengthen the
mhm,
teaching in the classroom or virtual classroom? So what is it
right.
in your program, and what are you going through right now, and what are you learning that you could really share with with those that are watching tonight and on the link?
The uh, it is difficult in this time of COVID with a virtual classroom. You don't have the connections with your students. It's tough. I will do Zoom meetings with 48 students, and I can't see them all. I don't know if they're understanding. I can try to talk to them as much as possible, but I do think COVID is not making nursing education any easier. And I think anytime you can get in and get some sort of relationship going with your students, the better. Some of the things we've done for COVID is we've kept our clinical groups are the same as their lab groups. So that's good and bad. I think it's helpful for COVID that they only have interactions with 8 students. And of course, the bad part is they only have interaction with 8 students. So unlike previous years where they would all come together and all 48 of them in a classroom and they could bounce ideas off of everybody, now they're bouncing ideas off of 7 of their fellow students.
I would love to get a little sense of just building relationships with your students in this climate, because, relationship, is so foundational. A healthy, connected relationship got me through my PhD program, actually, because I went on campus every 3 months. I met the faculty personally, connected with my cohorts personally, and it got me through. And in this virtual world, how are you kind of facilitating that team building, relationship building that really is foundational to everything we do as educators?
Mm-hmm. I think it helps to have a lot of lab, and we are fortunate. I do know some schools can't even bring their students in for lab, and we are able to come in and have in-person lab. And in our fundamentals skills, there is still quite a bit of lab. It's almost helpful for me anyway as an instructor when I'm in the lab with them that the same 8 students are in a group, because I kind of get to know those groups and I get to kind of be able to place them in that context. And you do get to know them a little better when you're spending that hour or so in the lab with them at a time. And that's helpful.
I actually got a comment here from Katie, who said that her comment on this topic was just being honest and real with them and acknowledge the struggle, the challenges, and saying it's okay to support each student to the end rather than tough love and failing them. So,
right.
Any thoughts or comments on that? Do you agree?
I totally agree. Right. Especially right now. Boy, we have some students who life is not easy for them on a normal day, and now we're throwing in COVID and maybe they just lost their job. So, yeah.
Exactly. And I just like to know, Jane, what was the connection between myself, KeithRN, and just, where did our paths cross as it related to just kind of like, I got a website, and it's kind of every educator has a little different, story. I'm just kind of curious where that connection.
Well, I'm just giggling a little bit because my colleague Susan is already, I noticed she's in the chat, and she said she's here. And so really we need to give her the credit for bringing us together. I actually was at a conference, a Nurse Tim conference, and I met you there.
Okay.
But I don't think I bought your book. I think Susan bought your book, and then I think I got your book later. And anyway, but Susan then has been using your case studies for a while, and she was just an individual member. So she signed up on her own, and then she finally said, I really love using these, and kind of talked us into getting a departmental membership. So we did that last fall, which turned out to be a wonderful deal for us, because then with COVID, we used a number of your case studies as clinical replacement activities.
Yeah, so I've got a whole series on COVID from the beginning of the ER all the way through ICU, and just different levels that you can kind of level throughout the program.
Right. We've used them in the first year of the program. It was our maternal child. It was supposed to be in spring, maternal child module. So we used a whole series of those for the students, and the students really liked them. I know Susan and her colleagues did actually reformatted some of the unfolding case studies and turned them into an inpatient, sort of a mid-fidelity sim, but where they
adapted, or how did they do? If she's not here, I know that she's not in the chat, but do you know how she did that, or what that looked like?
Well, with work, but she took two different scenarios, and so each one was a patient, and then they had two mannequins in the bed. We have two bed not simulation rooms, but patient care rooms. They're kind of designed like a hospital, and one instructor was the voice of the patient, was the doctor, was the everything, and then the students took care of these patients for, I believe it's a total of 2 hours that they ran through the different scenarios. And so basically taking your case studies and remaking them into a sim.
Right, they're kind of complete. They start with that scenario, and then you've got a set of vital signs, the assessment, the labs, diagnostics, and then the medication, they putting it together, and then the orders, the rationale, the nursing plan of care, the problems, complications to anticipate, and then the unfolding has a change of status. Now you got a new problem. Now what do you do? That's kind of
and with the change of status, then they had to pick up the phone. We have these little phones they pick up and they call, and I watched Susan do this for a couple hours actually during the time, and so it was very fun. She was the physician. She was giving them new orders, and then kind of did the whole role. But and that was for us. We wanted to be able to assess our final term students, and they had been basically kicked out of clinical. So they had one term left to graduate, and we needed some way to give them adequate assessment. So in addition to a number of VSIMs and other, clinical case studies and other types of paperwork, they did sort of this as their comprehensive checkoff, so to speak.
And so, they're really low tech. They're just a writable PDF document, but yet you're finding that you don't necessarily need to have this, avatars, and some of the technology is good, but you can actually have you found that your student learning and what your student feedback has been using these tools, Jane? Has it been, what have you?
Yeah. So I think the other time we met was when I called you up for your one of your office hours, and that's how I found myself here. But we did one of your case studies for my fundamental students, the tissue integrity.
Yes, and about that.
I was really, really happy with the way that turned out. And of course, like all assignments, I've got things I want to fix for it for next time, but I used it week 3 of the term. So these were really brand new students, and they they had, let me see, some perfusion assessment skills, some mobility assessment. I was doing tissue integrity assessment, and we gave them this assignment. We let them work on it in pairs. I did some just minor tweaks to it to make it look like the paperwork that we would have them do for clinical. And then also to add in some more, I wanted to put in some more tissue integrity assessment skills, since that was a big focus. But that was quite easy to do, threw that in there. And I was amazed that the students worked on it, they pulled it up, and I think the next day or two, I had a couple of emails from students, and it was, thank you, this is so much fun for us to work on. They were really thrilled. And I'd see them in the hallway, and they'd, this is just like being a nurse. So I kind of thought maybe I would overwhelm them, because I was asking them to interpret some labs. We hadn't even talked about labs yet.
Right. And that's the thing, the case studies, they use Chris Tanner's framework and model of clinical judgment, where it's like you have the scenario and then the vital. What do you notice that is relevant or most significant, and then why?
Right.
And that's high level reasoning. I mean, that you don't get that overnight, and especially early in the program. But even though you're asking these really kind of higher level reasoning, Jane, the students were able to, you raised a bar that was high, but it wasn't over their head, and they were able to rise to it without becoming overwhelmed. Is that been your,
right?
It sounds like that's what you're saying.
That's what I'm saying. Totally. I thought I might overwhelm them. I thought, in fact, if you read the little notes I put in there, it's okay. Take a stab at this. See how you do. I made sure that we didn't weight it heavily for their grade, because I didn't want anybody failing out of nursing school because this was so difficult.
Right.
But what I found is that, labs they didn't understand, they looked up, and they did a great job of interpreting them. They loved the towards the end of the case study, where you have the physician's orders, and why were these things ordered? I put that in just as you had written. Actually, I didn't make any changes to that, and they totally got it. They really, really enjoyed putting that all together.
Excellent. And so it wasn't overwhelming for them, even though you were kind of raising the bar. And it sounds like what you're doing, Jane, that's really cool, is that you're implementing principles of problem-based learning, which really is when you introduce a scenario and there's information that they don't know yet. It's like this is over their heads, but they look it up. They know where to go to find the information. So they're kind of teaching themselves. They're recognizing their knowledge gaps. They address them through the right resources, and then they keep going. They don't get stuck.
Yeah, it was fun. I mean, I definitely will do this more often. Definitely going to do this one again next fall with the students, because they enjoyed it so much. And I would look forward to,
because let's be honest, students, one of the things that I get back from educators who use some of the case studies that I've written, because they're completely open-ended, there's no multiple choice. They've either recognized what's relevant and then why it's significant. They have to write it all out. It's a lot of work. And the feedback that I get from students or from faculty is that my students are resisting because it's, they just want to be spoon-fed. They just don't want to do the work. But this is work. But what is it what's in that secret sauce, Jane, that they're responding to? Because to get that feedback, I find that really intriguing, based on other feedback that I get from faculty. But I just encourage them to be persistent and to persevere. But I'm just curious, if you were to flesh out the student feedback, what are they enjoying? Because it's, what is it that they're finding value would probably be the better question.
It might have been because they were so new. And I gave them an assignment, and that I was just quoting them. They said, we feel like we're being real nurses. And maybe it was because our other assignments were more like CNA activities. We're teaching them how to give a bath, and even though those are valuable skills, because certainly you have to know how to get a patient out of bed and transfer them safely. So I'm not belittling those skills at all. They're, everything we're teaching, I think, is of value, but they really liked that I gave them a higher bar, I think.
Yes.
And now
Excellent.
maybe later on in the term when they're tired, that higher bar doesn't sound so great.
Right.
But
But
we did do, like I alluded to, the a mother baby.
yeah.
Uh, we did the whole series, so that the pregnancy, the birth, and then the newborn care. And they did that one. We did get complaints about how much work it was, but we also reminded them, yeah, we're expecting you to spend a good 8 hours on each one of these. We know they're difficult. And kind of throw it back into context, because you're not going to clinical.
Right,
So
right. And there are different levels of case studies too, Jane. The
yeah,
skinny reasoning is very short. It's about 4 pages, while the unfolding has the same scenario, but it's over twice as long, about 8 to 10 pages student
yeah.
version. And so you can kind of, depending on what your needs are, it can be a quick classroom activity like the
Mm-hmm.
fundamental in the class, or it can be that clinical replacement,
Right.
like the longer version. But you're right, it is a lot of work from a student perspective. Did they do it together in small groups, or was it like an independent clinical assignment where they kind of had to, it was just them and the paperwork, and it
Yeah.
wasn't like it wasn't a group hug?
Yeah, the spring term, it was them and the paperwork.
Okay, that'd be a lot of work. I mean,
Yeah.
and that's, but it's good work. It's relevant.
Oh, I thought they were very relevant. I mean,
Absolutely.
I really am not, maternal child is not my specialty, and so I'm grading them, and I could tell they put a ton of work into them. They really um, put a lot of effort, and the value had to be there.
Did you find the answer keys helpful? Because that's one thing.
Yes.
I come with a fully developed answer key, either developed by myself if I wrote the case, or if I've got a collaborative faculty like OB. I'm not an OB nurse. I'm not going to
Yeah.
pose. I have those developed by experts who actually do the answer key as well. So
Yeah.
was that helpful, or kept you on track to be sure that you got it right, especially if you're not experienced?
I think there's a couple things, because we use them as clinical replacement activities. I'm not the only one that's grading them. We have multiple faculty grading their clinical group.
Yeah.
And so it's helpful for ensuring that we grade them equally, and there's not one professor grading them much easier than another. I mean, it really gives a nice standard for that. And of course, I'm like all faculty, and it's like, there's an answer key? Yes.
I was surprised as a new faculty, that when I would buy these case study workbooks and they had great case studies, where's the answer key?
Yeah.
A lot of these, products don't have the answer key. They have great
Yeah.
cases, but they're not there, or they're very minimally developed. And I said, well, if I'm going to write case studies for faculty, I know what I value, and that's a good answer key. So that takes me so much longer to do, because as you know, it's a lot of writing.
Right.
A case study scenario, I can do that in an hour. An answer key is like 8 to 10 hours.
Right.
Really
It's hard.
Diligent work. It's not easy. But I think it gives it additional value and makes your job a little easier, I think.
Absolutely. Yes. It was very nice. So, and even though I did a little bit of revision and I added some of my own things in, I only had to write an answer key for those little pieces, and the rest of the answer keys are really well developed and very thorough.
Yeah, and that's the thing, Jane. That really, when you look at these cases, you can modify them. They come with a great foundation, but you can tweak them. You can kind of, add or subtract. So you can kind of, based on what level you're teaching, whether you even be practical students, there might be some things that you may need to adjust, but you have that flexibility as an educator to kind of make it your own. It sounds like that's what you've been doing.
Yeah. Yeah. I mean, just a quick, easy example is they had the lab results. So our students, at this point, they didn't even own a lab book yet. So I didn't want them looking up lab results. I didn't want them to going to the internet to find a normal lab answer what the normal labs should be, because they would get a lot of responses. So I put my own, these are the normal labs. This is the patient result, and then you also had a trending value there. So that was really great too. So their previous admission.
Reasoning skill, that
Yeah.
trending of data from one level. Where's our direction going? It's one thing to say, oh, my potassium's high or it's low.
Right.
Okay, well, where's our trend going? What does that mean?
Right.
That's higher level thinking.
the students picked up on that. They would be able to say that, it's okay now, but it's trending high. I mean, it's been moving up. So I thought that was really great. But that's just an easy example where I put my own normals in for them, so they wouldn't have to try and find those normals. They could still have to look up the lab, but
Excellent. Excellent. No, I'm just kind of curious, Jane, just in closing here, just a couple of quick questions, but would like to know what other strategies have you used successfully to develop the thinking with your fundamental students? Is there anything else that you're doing? Case studies are a great approach. That's a great starting point. Is a great foundation to build upon because it brings that context, brings practice. But what else have you found effective that other educators could hopefully find value in?
I think I know you had asked me this question. So one of the and just reflecting, my favorite question to ask in the classroom is, and I teach a lot of pharmacology. I should tell you that that's one of the topics I teach, and I will just ask them if there's a side effect or there's a what complication are you looking for, and if I'm writing something out, it's heart failure. Heart failure is a side effect, or increasing heart failure. I love to ask them, okay, what's that going to look like?
Like clinical symptoms, like what would be the cluster of symptoms that you're looking for that would...
Right. And I think one of the favorites that I used, that I found out as I'm doing this one all the time, is there, when we're talking about Stevens-Johnson syndrome, for instance, and some medications can trigger Stevens-Johnson syndrome, and you see your students and they're taking their notes and they're nodding their head, and then you throw out, okay, what's that look like? And you just like, I don't know, and so I said, well, somebody, you got your computer there, you Google this, and okay, they look it up and they start reading me the Wikipedia definition. I said, no, look at the images. And they're like, oh my gosh. And so that's one thing I really like. If you've got computers in your classroom, use a computer and use it to your advantage. But also don't be afraid to ask them what does that look like? Don't just give them a complication or a diagnosis or a symptom. What does that actually look like in your patient? What does hypovolemia look like? They don't come in with a sign that says I've got hypovolemia. What does it look like?
Yeah, for some reason, as an ER nurse, what came to me with pharmacology, how about angioedema?
Oh yeah.
What does angioedema look like when it's the real deal?
Yeah.
That's a great image, and you can find those pictures of the swollen lips and potential airway. What are your concerns? I mean, you can take one image, Jane, and you can get so much high-level reasoning by just taking it to that next level, asking the next question.
Right.
What does that look like? But then it's like the next question is, and then what's your nursing priority? What could go wrong with angioedema or Stevens-Johnson or anything else that you're wanting to kind of go deeper with?
Right.
So yeah, I love that. And you know what, whether you realize it or not, that's your nurse practitioner coming out with that question.
Oh, okay.
That's a provider type of question. What are you seeing, and then putting together to kind of put together a diagnosis, diagnostic reasoning. But we as nurses need to have that same kind of, in essence, that diagnostic clinical reasoning. What does it mean and what does it look like, so you can recognize it and say, oh, that is angioedema. I got a medical emergency.
Right. You're right. You've got to know what you're looking for.
And not just say, oh, they got swollen lips.
Mm-hmm.
That's not the same.
No.
So I really love what you're, just that higher level reasoning. And your fundamental students, they can rise to that bar, Jane. They're not intimidated, and they actually do pretty good with that question.
Yeah, they do. I mean, it's sometimes I get a little startled look, they'll be, and I said, now think about it. What is this going to look like? What are you going to see when you walk in the room?
No, and I think, if the educators listening tonight, if they get nothing out of tonight's, I think they did, but that is one question I would love to see other educators use around the country, because it reflects the thinking. It's all about developing the reasoning, the clinical reasoning that leads to clinical judgment. Mm-hmm. That's what we need to start. And we can do that from day one, Jane, can't we? Mm-hmm. We can do it from the first or second, third week. and just keep going throughout the program.
Yeah, I would definitely don't be afraid to challenge your students.
That's right.
They work really hard. They take a lot of A&P. They take micro. They take chemistry. They can do this.
That's right. That's right. So Jane, last question. I want to know your pearl. You've been a nurse educator for 20 years. That's a lot of time. With that comes wisdom. And I'd like to know if there's one or two pearls you can share with the audience tonight that would just really help any educator that regardless of where their station is, what they teach. I'd love to get that closing wisdom pearl.
Okay. So for clinical teaching, I think, which I think is very difficult. And what I found is that I'm working with my students and I'm running around, and I get tired, and so it was very helpful for me to have a little cheat sheet of questions to ask my students. And so I have that in my notebook. So when I am and I don't think it's necessarily, I shouldn't say I'm tired, but I think it's mentally exhausting being a clinical teacher.
It is. It's mentally and physically.
Yeah. And so it was very helpful. It's always been very helpful for me to just, in my little notebook, have questions that I want to ask the students, because sometimes I will show up and I'm outside their door and it's like, what are we doing here? And so I could, so questions, just, what are your top, what is one of mine?
Yeah, I'd like to share at least 2 or 3 questions, Jane.
Okay.
And go slow, because those are, I think, asking the right questions. And I think what we need to remember as faculty, that we could ask these same questions in the classroom.
Right.
We don't have to wait for the clinical. When we're teaching med-surg content or OB, peds, whatever it is, we can bring in these questions into our classrooms as well. But I want to know, what are your 2 or 3 questions that are your favorite?
Okay, so some of them. So let me see. What complications are you assessing for in this patient? And sometimes I'll ask it, what's your worst case scenario here?
Yep, that's one of mine. That's one of the ones that I use in practice, that that a nurse does in practice. You've got to be looking for that worst possible.
Right. And I'll often tell them, you're not going to find things you're not looking for. So I want to know what you're going to be looking for. Yeah. What are 3 things that are going to show you this person is improving? Your patient's improving. I like, pick a number, but how are you knowing your patient's getting better? And then conversely, what are 3 things that are telling you that this person is not improving? What are things, what has to happen for this patient to be able to be discharged? Sometimes I ask that, if you could fix one thing, what would it be in your patient? If you had a magic wand. Because oftentimes there's just like one thing that needs to come together, and then this patient can pull it together.
And I would add one more question that kind of along that one thing, is that one of my favorites is, what is the one thing you can do today to advance the plan of care?
Yeah, that's a great one.
They're just, what is that one thing?
Mm-hmm.
And I use that in practice all the time. It's like, what can I do to really push this patient to get them one step closer to discharge?
Right.
What does that one thing look like? And identify it and then do it.
Right. I also, and this one's, maybe it's just me, but I also have to give my students permission to slap my hands if I'm getting in the way. Because I tend to want to do the skill for them, and I'm very hands. and so I at the start, I just say, if I'm taking over, just slap my hands. I'm okay with it. I know I do this. So,
I got a great question from Julie, who I think has a burning question she'd like to answer. I'm going to throw on the screen. Okay. She says, what is your advice for new didactic and clinical educators coming from a full-time ER, but they don't have experience teaching clinical? Would you say that one of the most powerful things you can do as a clinical educator is develop the thinking by asking the right questions? Was that, that's how I would answer that question, is that you need to stay focused on developing the clinical judgment and the thinking of students by asking the right questions, like you have done a great job of sharing. The tasks are secondary. Med-admin, Foley Cath, blah, blah, blah. They're important, but that shouldn't be the focus. What would you add to that, Jane?
I think exactly that you really want to develop the thinking. your job is to make sure your student is running through the different scenarios in their head like you are. You, as an ER nurse, I'm sure have your brain has run through things you need to assess, things you need to take care of. I know these are the top 3 important things I want to deal with this patient, and this is where I'm really needing to be for this particular patient. But that needs to be imparted to the student. So your job now is to make sure you're asking the right questions to get the patient, or excuse me, your student thinking that like a nurse, using those questions.
Absolutely. Absolutely. And that's great feedback, Jane. Thank you so much for sharing. And, stay with us for just another minute or two here. I'm going to basically close here, but we're going to come back for some questions. So if you've got a burning question for Jane, I want you to put it in the chat. And we're going to come back to Jane in just a moment here. But I just wanted to just kind of close and let you know that if you would like to just road test, if you've never heard of KeithRN before, you'd like to know what are these case studies they're talking about, no worries. I've got a free case study I just want to share with you. It's on my website, KeithRN.com. I've got blogs with other information. But more importantly, if you go to the website, at the top of the website, there is a COVID-19 case study waiting for you. You just need to give me your email address. You can sign up for it and get the download. And just want you to know it's a skinny reasoning, which is my shortest and most concise level, but it is a very strong for fundamentals to med surg with isolation principles, as well as the principles of just basic recognition of COVID and priority setting with respiratory distress. And so that's available there. Also on KeithRN, I've got about 25 topics of different levels of complexity of different topics across the curriculum. But like Jane is using in their program, the best value I have for nurse educators is the all-inclusive membership. And that's at thinklikeanurse.co is my information page. You can see about 110 topics. You scroll down just a little bit, you'll see the link for the topics. You can see all that's there. And most of these case studies have at least 2 and 3 different levels of complexity. So whether you want to use it as a classroom activity that's short and concise, or a more complex, longer version, unfolding reasoning, those are there inside the membership, as well as webinars for faculty development with contact hours, other handouts for clinical, and really just more of a comprehensive curricular approach that are all derived from the scenarios from clinical practice, from my lens of practice or those of other educators in the specialty topics who develop these. So they really have that clinical salience that are, again, based on Tanner's framework of clinical judgment and my own lens of practice that really has a very simple but consistent framework to help develop the clinical judgment that students require for practice as well as licensure, including next gen. And so I want to bring back Jane tonight. And while she's still there, I forgot to put her on, but she's still there, stayed with me through that. Jane, just wanted to know, for those that were watching tonight, I would just like to know what your takeaway was or what specific questions that you have. And, Katie Beth has a great question. Says we should develop a collaborative tip sheet for clinicians transitioning to practice. And, I'm just curious, Jane, do you have any other thoughts or wisdom related to that transition, a successful transition for clinicians to successfully make that transition to academic practice? Any other thoughts you'd like to add to that? Because I think that there's a need out there. I'm just kind of curious how you see it.
So I would say I also need to give credit to some mentors. So I will give a plug out there to experienced faculty being willing to work with new incoming faculty, trying to put yourself in their shoes, that they don't know everything that you do and work with them. I think we're really going to need to be growing our new faculty. There's going to be a shortage. I do highly recommend, certainly your website and your products are great. So is Nurse Tim. Nurse Tim's got some great workshops for new faculty. And then the Elsevier, the Iggy boot camp. Like I said, I'll give a plug for that because I learned a lot at there. boot camp. So if you can go to some of those workshops and go with an open mind, wanting to learn some things. Let me see, Linda Caputi, like I said, she's one of my favorites. Get her books. She's got a number of things as far as developing clinical and critical thinking skills as well.
Oh, excellent. And I would agree that, the mentor piece, I think, is the missing link
Mm-hmm.
in nurse education. I mean, I was an expert nurse, but my transition to practice in academia, they were so busy and overwhelmed that I had a mentor
Mm-hmm.
wasn't available readily to me.
Right. And that is really key. I mean, I have learned from so many other faculty. You can go to a test item writing workshop, but it is really helpful to have somebody right there rereading your test questions with each exam. That is a hard thing to develop, and it's not going to come from just one workshop.
And one of the questions Julie asked was, how do you organize Medpass in clinical? I'm just curious, with fundamental students, I'm assuming 8 to 10 in your, what's a typical clinical size in your
Yes.
part of this in your program? And how, I think that we can learn from each other by just talking, just for a moment about, what do we do in clinical with Medpass that you find to keep your sanity and you don't lose it by the end of the day?
Okay, so some of the things we do, we have 8 students in a clinical group. So for the first couple of med passes, certainly I'll divide them up, and I might only give, maybe for the morning med pass, 4 students will give the morning med pass, and then the other students are going to give the later on, maybe noon blood sugar or insulin or something like that. The other thing that we try to do as a program is we have what we call alternative clinical experiences, where they will do a little community rotation. And so we try to rotate 1 or 2 students off the floor, especially during that med pass time. Yeah. Now, because of COVID, we are not able to do that as much. So we are in the process of designing, and we've used these before too, but these are Linda Caputi exercises. And actually a KeithRN case study would work well too, where instead of they're actually being on the floor doing clinical, they are doing some alternative type of clinical experience. So Linda Caputi would have them doing chart researching and dealing with other patients and more in-depth work on a patient where they later present. But you could easily do a case study as well and just have them off the floor for that time.
Yeah, no, and I would add that I developed about 5 years ago, based on Linda Caputi's I looked at that alternative assignment, and I basically began to think of it in the clinical reasoning framework. And actually inside the membership under clinical tools, there is an alternative clinical assignment that is about 6 pages. 2 students go off the floor. So you can, if you're in the real setting, you can take 2 students off the floor. And I have some guidelines as far as the type of patient that would be best to go a deep dive in the chart together. But it's based on principles of clinical reasoning. And doing that deep dive, kind of using the format of the case studies, but with the real patient, they actually do an assessment on the patient and, bring it all together and do like a post-conference grand rounds. And so they present this in post-conference, those 2 students who are off the floor, but they got a very meaningful clinical reasoning activity that's a little bit more than a case study. Because it's a real patient that they're digging deep on. Really provides that value. Yeah,
and those kinds of things I think are great. And we have used those in the past, and we're bringing them out due to COVID if we can't rotate to, to a community site or something.
Awesome. Yeah, and just a closing comment from is Susan Miller? Is she your colleague?
Yes.
she's your troll tonight.
Okay.
She also said this, and I'll throw it on the screen. She said, "Don't forget your clinical roots." And I think that's a principle, Jane, that I think is a great point to close with, is that you may be a nurse, you may be a newer nurse educator, but you're immersed in the clinical setting. You know clinical practice. And so in essence, you need to bring that. You're a strength and an asset to your program. You may not be the most experienced educator, but you are an expert in your current and recent in practice. And many of your colleagues are not. That's a weakness for them. You have a strength. Together, you're stronger. And so therefore, bring that clinical salience into your content and as well as in your clinical. Well, how do you think as a nurse? What are the questions you ask as a clinician when you're caring for patients? It's no different. We're just translating our internal thought processes and try to make it visible.
Right.
That's the essence of a good educator. And that's what I try to do with the case studies, taking how I think as a nurse using Tanner's framework and my own lens and make it visible in the case studies. Anything you'd add to that? Great question, Susan.
Yeah, and I think, I think one of the things that helped me too when I was first teaching, because that's very true, we are thinking these things and not even realizes we're thinking these things. We're so used to clinical practice, we know what we're going to do as a nurse. And I think it was very helpful for me to actually pause and start talking out loud to my student, and then phrasing that into, instead of telling them what to do, asking them questions. But it took some time for me to actually stop and pause and say, all right, this is what I'm thinking. Okay, now I need to phrase it in a question to my student, and to get them to that point where they're able to think like a nurse.
Yes. And actually, there's some strategies in the literature called think aloud. Using that thinking aloud to develop clinical judgment. That's another topic, but that's a very effective strategy to kind of just think out loud. What are you thinking? And a good question I have found, Jane, like you mentioned, you can read a student's mind by asking the right questions and help guide that learning,
right,
decision making. Just in closing, I think Julie has a final thought, and I'll say amen to this. She says this: I find that I try to teach more to real world versus NCLEX. Now that's an interesting thought, because I think that as educators, we oftentimes let NCLEX inform all that we do. And what I would say is that when we look at next generation that's coming, next gen NCLEX and the NCSBN model of clinical judgment based on it for next gen, that's Tanner's framework of clinical judgment. If you know Tanner's framework in those 4 steps, they are immersed in the 6 steps of the NCSBN model. And I think that we can do both, Jane. Would you agree that if we teach real world clinical decision making, base it on like principles of Tanner's model and her framework, we can basically do both. We can both teach real world practice, and by the way, they will pass the NCLEX.
You're right. I think that's true. I think we shouldn't be so worried about passing the NCLEX that we're not teaching them how to think, but the NCLEX is moving to, they are going to have to be able to think through some difficult problems. They do a lot of prioritization and what's going to happen. So definitely, I think you can do both.
Yeah. And, I would even say, Jen, what I saw with those questions that you asked about, like what are the three pieces of how did you phrase it? The 3 things that will show that, the 3 pieces of clinical data that will show that your patient's either improving or declining. You know what? As I've been to next gen conferences, that is a high level next gen question. Where you can have multiple pieces of data. What are signs? What are 3 symptoms out of 7 or 8 that are showing your patient's improving? So those questions that are really reflective of nurse thinking, if we teach that, the NCLEX will take care of itself. I totally agree. And I think that's a paradigm shift. If we could do one thing as nurse educators, let's start focusing on preparing our students for practice. And I think a lot of our conferences are about do this NCLEX success has become an unhealthy mantra.
Yeah.
We need to kind of hold a little bit more loosely and start focusing more on let's prepare our students for practice. And if we use best practice, they'll pass the NCLEX. So yeah, thanks so much for sharing. We've gone a little bit over today, Jane, but we've got a lot of people still with us. And so you know what? They haven't gone away. They found this valuable. I've had a lot of fun. This has been a great conversation. And
yeah, it's been great. I like this next question too.
Yeah. You want to answer that?
Well, replying to Katie Beth, I think out loud in post-conference in their provider report, I asked them questions, as if I were picking up the patient or digging in this chart. I love having the students give report, and then so go around, give report. Okay, now which patient are you going to go see first?
Yeah.
Just those little practice things.
Totally agree. No, it's excellent. And so Jane, thank you so much, and thank you so much for taking the time. And it's been a valuable time together. And thank you all for listening in. And share this link if you found this helpful and a good conversation. The link is again, you can just copy and paste off KeithRN, Think Like a Nurse. And I just want to get the word out. My heart is just to influence nursing education, to strengthen our students' preparation for real-world practice. Patient outcomes will be improved. And yes, they will also pass the NCLEX. So blessings to you all. Have a good night. Take care.
Yeah.
Thanks, Jane.
Well, thank you. Had fun.
I did too. Thank you.